PhD to associate professor, which means I have tenure next.
Okay.
Thank you very much for that.
I'm doing good.
I appreciate it. I will never lose my job for saying anything unpopular. All right, so thanks everyone for your patience, and I wanted to make sure you're all aware of kind of what is in the Affordable Care Act. I know a lot of you are doing outreach and community events that would help people enroll in coverage programs that are created by the Affordable Care Act. So I'm going to make sure everybody kind of is comfortable with the content here, and so we'll go through some of these slides and we'll take a question and answer at the end. I think, as Dr. Rogers mentioned, the bill is quite expansive, but the core of it really deals with access issues, meaning increasing the ability of people to get into Medicaid, and also increasing the ability of people to buy private health insurance on their own, either with their own money or with federal tax credits to help them purchase insurance coverage. Of course, that is being done through the private market, so we're not seeing government-run plans like Medicare able to sell private insurance policies to citizens directly unless they're over the age of 65, and that was one of the complaints of more liberal parts of the Democratic Party, in that there needed to be more of this government public option available to people. And I think that even though Medicare has been a successful program, it still is one of the most expensive programs we run, and per capita we spend a lot on the over 65 population. So I don't know that it's as easy as just saying, let's scrap everything we already have from a political standpoint as well as a policy standpoint and replace it with Medicare. We have to remember that Medicare is a fairly tightly controlled program. Doctors like Dr. Rogers are paid probably about 90% of the cost that they would normally spend delivering care through the Medicare program. So if you were to replace the entire system with Medicare, I'm sure doctors would be just as upset as individuals about the choice of doctor they might have. And so our system has long been based on this idea of cost shifting, where the uninsured, the Medicaid population, and the Medicare population, where patients are actually losing money for their physicians, are then getting those costs are being offset by private insurance companies like Blue Shield, Blue Cross, Health Net, Kaiser, et cetera. And I'm not necessarily a proponent of private insurance, but our system has been built that way, where this cost shifting has always been going on, and it means that people who have commercial insurance through their job or buying it on the individual market typically are being overcharged because they're paying for the services delivered to the non-paying or underpaying population. So the commercial insurers are passing those costs on to our employers, passing those costs on to individuals, and that's why it becomes very unaffordable for people to have individual insurance without some level of protection or some level of help. So I think the ACA, even though it has its flaws, tries to deal with that cost shifting issue by making sure that everybody at least has access to insurance coverage, but also that it's affordable insurance coverage, so insurance companies don't have complete ability to just raise premiums for no reason and continue to kind of try to get back the revenue they're losing from the uncompensated care patients that physicians are seeing, those types of things. So the main goal is really around access to care, but there are other aspects that I'm happy to take comments and questions on in Q&A around bending the cost curve or reducing the level of spending. And unfortunately, probably the biggest cost saver over the past couple of years has been the sequester cuts that basically slashed Medicare reimbursement. And it's it's not because of the Affordable Care Act, it's because Republicans and Democrats kind of couldn't agree on a budget solution and had to agree on a 2% cut across the board in both defense programs and in healthcare programs. And so certain parts of the Medicare program have been cut by that, and our decrease in healthcare spending we're seeing now versus the normal rate of growth is related to that budget cut, not necessarily the ACA. It's partially related to how the economy is doing and people's spending in healthcare. So I don't know that we can assume that every ill we see in our healthcare system or every change we see in our healthcare system, even if it's saving money, is the result of the Affordable Care Act. It's quite a complex law, and I think it's important to understand what kind of external impacts it could have, but also don't assume that it does everything to our healthcare system. Really, these access provisions probably affect about 10 to 15% of our population. Luckily for us, about 15 to 20% of our population is uninsured. So the hope is that it will address those problems and get more people into insurance coverage. But even after 2020, when the law is fully implemented, even if all the states expand their Medicaid programs and all the states and federal government runs a good exchange website and allows people to buy coverage, we still anticipate about 5 to 7% of Americans remaining uninsured, either because they decided not to buy coverage on their own, or they're undocumented, or they don't qualify for subsidies, and they still can't afford it regardless of their economic situation. So I think it's important to put it in context that this law really only touches on a little sliver of our healthcare system, but there are lots of ways in which we're hearing that it affects our healthcare system that might be a little bit exaggerated. So it gets into incentives to purchasing insurance, but also trying to streamline and expand the Medicaid program, which is a program for lower income individuals. Typically right now, it's only lower income individuals who are in families or who are elderly or disabled. So a childless adult who doesn't have children cannot currently qualify for Medicaid in the state of California, but they will be able to qualify for Medicaid on January 1st in the state of California because of this streamlining of the process and also a change in how you become eligible for the Medicaid program. So first up is this expansion of Medi-Cal. So you'll all remember that the Supreme Court weighed in back in 2012 on the fact that the Medicaid expansion would be voluntary, that the way in which the Affordable Care Act changed Medicaid reimbursement, and the fact that the federal government was going to pay 100% of the cost of Medicaid for this new population of childless adults was viewed as coercive by the Supreme Court, because if you didn't perform and expand Medicaid, you would then lose your existing Medicaid programs. So the Supreme Court ruled that that was unconstitutional and invalidated that part, but it did say that states were allowed voluntarily to expand their Medicaid program under the rules of the Affordable Care Act. So at this point, 25 states and Washington, D.C. have done so, and other states are in phases of doing it and getting concessions from the federal government as a condition of doing it, and other states are saying no completely. But to give you an idea, 90% of Democratic governors have said yes to the Medicaid expansion. 25% of Republican governors have said yes to the Medicaid expansion. And there are far more Republican governors in the U.S. than Democratic governors. There are 31 Republican governors, and 7 of those states have actually decided to expand the program. But some of them are dealing with it in creative ways where they're saying, well, Medicaid has welfare stigma, Medicaid is a government-run program, and we want to use this Medicaid money from the federal government and allow people to use it to buy private insurance through the exchanges. And currently, the federal government has been pretty flexible with those ideas and has granted waivers to Arkansas and Iowa to allow them to do so. So in Arkansas and Iowa, you'll see people not going into Medicaid directly. They'll be going to the exchange, but Medicaid will be paying the bills for them because it's more politically feasible. So we're likely to see those types of options moving forward in states that don't expand, because private insurance is far more comfortable for a lot of conservative lawmakers versus expansion of a public program. But in our new Medicaid program, childless adults will now be eligible based on what's called modified adjusted gross income. This is basically line 37 of your 1040 with a few exceptions around alimony and farm worker subsidies and things like that, and retirement income. And as long as that income is under $15,800 or 138% of our federal poverty guideline. So our federal poverty guideline is set each year. Right now it's $11,490. And if you multiply that by 138%, you would get the $15,800 guideline. So if you have a single person who walks up to you and says, you know, I heard about this Obamacare thing and I make $15,000 a year, it's very likely that they will qualify for the Medicaid program, and they don't need to go through Covered California to sign up for coverage. They don't have to pay anything toward their coverage. They would just get Medicaid for free, even if they don't have kids, which is currently a criteria for eligibility. But all states, including California, regardless of whether they expand Medicaid, have to adopt this new simplified Medicaid requirement around income. And it does away with what's called the asset test, which used to be used to see if adults had too many assets, savings, car, house, things like that, that would disqualify them from the Medicaid program. That goes away for anybody who's under the age of 65. It still exists for those who are over 65 or disabled, because they're in a separate part of the Medicaid program that already existed predating the ACA. So the Medicaid expansion is a significant option. Here in LA County, the 2 plans that do Medicaid managed care are Health Net and LA Care. So if you go into Medicaid, Medi-Cal in the state of California, you go into LA Care, Health Net, and then LA Care has these plan partners. So you might be able to choose within LA Care to go into Kaiser Plan Partner or choose to go into the Care First Plan Partner. So in shopping around for your Medicaid doctor, you can look at the networks that are listed on the LA Care website and see which plan you should be assigned to under that LA Care umbrella. So Care First has very good pediatric networks because of the fact that they're contracted with Children's Hospital LA. LA Care might have a contract with the LA Care Independent Practice Association, a bunch of medical groups, but they might not have as many pediatric specialists or anything like that. So you kind of have to be savvy about shopping for a provider and then looking at the website and seeing where, which plan provider they would assign you to. And of course you could have access to the Kaiser network through LA Care as well, because if you sign up for LA Care through Medicaid Managed Care, then you can choose the Kaiser plan partner and you get the full benefit of being a Kaiser member. You can go to any Kaiser facility statewide. And so there's quite a bit of choice there. There's no longer this issue of if you go into Medi-Cal, nobody will see you, because they now have these provider networks that are fairly expansive and have to meet certain regulations that the state lays out. Whereas we used to be in this world where Medi-Cal paid very low rates on a fee-for-service basis per visit to doctors, and a lot of doctors said, no, I don't want to take Medi-Cal at all. Then we move to private insurance. So really the core of the ACA and what all the hubbub is about currently in California is around this gateway for people to buy private health insurance coverage. So here in California, it's called Covered in California. It's called the State Health Insurance Marketplace. We are one of 14 states that designed our own. There are 36 states out there that are using the federal system right now. A couple of them will be starting their own system next year. But for the most part, a lot of states that decided not to expand and create their own system passed up grants and federal funding that would have allowed them to create that website and have deferred to the federal government. And the federal government's website, of course, has had fairly limited success at this point. But to put it in context, California was very active and an early adopter. As you know, Councilmember Blumenfeld mentioned, in 2011, Governor Schwarzenegger and the Democratic legislature decided to expand Medicaid, or push toward expanding Medicaid and create their own Covered California Health Insurance Exchange. They appointed a board to lead that exchange. They gave that exchange quite a bit of power in the market. In California, we have what's called an active purchaser exchange, which means our Covered California board can go out and negotiate with health plans directly to set premiums. And they can require them to meet certain quality benchmarks. They can require them to cancel policies as of December 31st if they want to, which is exactly what happened. So Covered California has lots of power to shape the health insurance market. Covered California also made a very important decision to standardize benefits across the individual market for health insurance. So the fact that you see that a bronze plan inside of the exchange and a bronze plan outside of the exchange look exactly the same in terms of deductibles, co-pays, cost sharing, is because Covered California exerted that authority. In other states like Colorado, they don't have that authority. They set them up as a very passive purchaser and they are allowed to take in any insurer that wants to do business and has a license to practice insurance there. And so you might see 40 different bronze plans from 10 different insurance companies. They're all offering these different options, and it's very hard to choose. You can envision, it's hard enough looking at the 7 different plans that you might have access to through in one metal tier of the exchange plans. But if you're trying to shop between 40 and one of them has a $5,000 deductible and one has a $4,500 deductible, and the networks look the same, and you're trying to pick out which benefits don't match and things like that, it becomes very difficult for consumers. And I think Covered California made a good decision to make it as simple as possible and standardize products across the individual market. So that's one thing that we did fairly well that has probably helped us a lot, because the federal exchange has to run, I think the federal exchange has to run 16,000 different plans. If you can envision putting that computer system together, Covered California probably has to run about 100 different plans. And so you can see the kind of the level of IT support you would need at the federal level, especially when the bill was designed to have states run their own exchange. The federal overseers were thinking, we'll probably end up with 5 or 10 states deciding to do this on their own, or to punt to the federal government, and the rest will do it on their own. And it turned out 36 did it. So they had a much larger task at hand than they expected. And unfortunately, that was a bit short-sighted and has created this political issues currently. There are 2 components of the exchange. So there's the shop exchange, the small business exchange, as well as the individual market exchange. They are separate in Covered California. So if you are a worker for a small firm that has fewer than 50 employees, they could decide, we're going to buy our employees coverage, we're going to contribute half of the premium on their behalf for that coverage, and we're going to let them go choose a plan in the shop exchange. And they would pick a reference plan. They would basically choose, like, we are going to buy them the Kaiser HMO plan in the silver tier, but they're allowed to choose whatever they want. So you're basically taking that budget that the employer gives you and going and shopping around within the exchange, which is a huge difference from what we've seen currently in the small group market, where if you have a firm that small, they're typically offering you one plan and you either take it or leave it. You don't have the choice of shopping amongst plans with that budget given to you based on your reference plan. On the individual market, also back to the shop, so it's important to distinguish that even though it's called Covered California, the shop exchange, that small business exchange, doesn't come with any individual tax credit subsidies like the individual market exchange. So you're reliant, if you're getting coverage through the shop exchange, on the money that your employer is contributing on your behalf, and then your own money out of your paycheck to contribute to the plan. You don't get any additional tax credits. Whereas if you're shopping in the individual market based on your income, you may end up getting a tax credit that helps you buy that premium. Because really what Covered California is trying to do, and what the ACA tries to do, is make it like the small businesses and the individuals who have always had a very hard time shopping for coverage are now acting like a large employer. They're now acting like Walmart or Target or the University of California in terms of negotiating and getting these bulk discounts and the ability to spread risk among a large population in this new exchange. They're basically just setting up this purchasing authority that negotiates directly with the insurance companies, and then you sign up to be a member of that purchasing authority, right? And you're protected by those laws and the rates that they've negotiated, and you never had that power before because you've been sitting out there in the individual market all by yourself, carrying with you a pre-existing condition and health risks that insurance companies don't want to take on. It's important though that we remember that the Covered California is only a part of the market. So when we see that 159,000 people have signed up for Covered California thus far, there's still a market outside of Covered California that's also the individual market that is called outside of the exchange or non-exchange, where people can still buy coverage, but it looks exactly the same as Covered California in terms of the benefits covered, the cost protections, the out-of-pocket maximums, things like that are consistent across both markets. So you could still, if you're very frustrated with the Covered California website, you can go to the Blue Shield website directly and sign up for the exact same plan you could buy in Covered California. What you're passing up though is tax credit subsidies and possibly cost sharing reductions depending on your income. But if you're a family of four earning $100,000 a year, it's perfectly fine to do that, and you're actually buying, you can buy the exact same plan in Blue Shield that you would buy inside of the exchange through Blue Shield. You're just neglecting the fact that you might qualify for tax credit subsidies. So there's still this existing small group market, there's still an existing individual market, but they've now been told you need to conform with what Covered California is doing. It's standard across the entire market. You will see some plans out there that, like Anthem, for example, is offering plans that look a tiny bit different than what's offered in Covered California. They're required by law to offer the same plan inside of Covered California as they do outside of Covered California, but after that, they can put in some kind of odd combinations of benefits, or not benefits, but cost-sharing deductibles and maybe even provider networks. So it's possible that, if you're upset that Cedars-Sinai is only in the Health Net PPO network, it's possible you could look for an Anthem plan outside of Covered California that has a contract with Cedars-Sinai. So you have to be kind of savvy about figuring out, do I really want this network and this provider, or do I want the tax credit subsidies, and where should I buy my coverage? And it's actually not bad for people to buy outside of Covered California in the individual market because the products are combined, right? They're the same risk pool, and we're then protected from risk where people stay uninsured and stay out of the system and reduce the ability for the system to stay intact and be sustainable over time. So there are 10 essential health benefits that Dr. Rogers mentioned. So the key things to think about are, in the past in California, you often saw individual market plans that didn't have prescription drug benefits, didn't have maternity coverage, didn't have mental health and substance use coverage, and maybe had limited pediatric services related to oral and vision care. And now there's this new standard, the 10 essential health benefits, that is required for every individual market and small group plan to carry And these plans stand as a benchmark for employer-based plans, but they are not required for employers. So employers could decide, we're not going to offer these 10 essential health benefits, we're going to offer another benefit, but the value of that benefit is equivalent to these 10 essential health benefits, so we're allowed to do so. So employers are using this calculator to figure out, is the insurance we're offering to our individuals who work for us adequate? But if you're working in a firm that has fewer than 50 employees, or in the individual market here in California, they have to abide by these 10 essential health benefits. So that's why there's all these plan cancellations, because in California we didn't have maternity and newborn care in every plan. We didn't have mental health substance use disorder services in every plan. We didn't have prescription drug coverage in any plan. In addition to that, we didn't have maximums on the deductibles people could have. So now we are moving to a world in which the individual market has a $6,350 individual out-of-pocket maximum if you're in network. You cannot exceed that if you're in a Kaiser HMO and pay anything else. Once you hit $6,350, you're completely covered 100%. There's no more cost sharing, no more co-insurance. And in our current market, we saw $10,000, $20,000 out-of-pocket maximums. I was talking to somebody recently who was in Colorado where they had a $30,000 out-of-pocket maximum in a year. So by constraining that to a lower level, premiums might go up, and these plans had to be canceled to comply with these new requirements. So you're getting more for your money in this case, but some people are complaining that I don't use maternity care, I'm a 62-year-old male. Well, if you were married and 30 and trying to sign up for coverage, maybe you would use that benefit. So I think we all have to think about insurance benefits aren't just for me, they're for the entire pool of people, the entire community that's covered. And the fact that people are covered for things like adequate maternity care and mental health substance use disorders is actually protecting all of the rest of us in that same community from overspending on services that aren't covered, or exacerbated chronic illness that ends up costing us more in the long term. So there is one component of the ACA that relates to employers and what their responsibility is in the future related to offering insurance coverage. So in 2015, employers with more than 50 full-time equivalent workers who are working 30 hours a week or more must provide affordable coverage, meaning it costs less than, or 9.5% of your wages or less for your share, and it has to be minimum value, which means it has to meet a 60% guideline based on the calculator, based on the essential health benefits. So it has to be kind of a robust benefit package at a fairly low price, although a lot of people argue that that 9.5% mark is very high, and there's also a problem where it's only based on your single coverage level. So if they're saying by offering you single coverage for yourself that's under 9.5% of your income, we are meeting our requirement, and we can now wash our hands of the rest of your family. We can charge your family 25% of your income, but we are still meeting our obligation and avoiding any penalties that come with not offering coverage to those dependents or spouses. So if the firm does not comply with this part of the law, then in 2015 they'll have to start paying fines. And they can choose between paying they have to pay the higher of two amounts, either $2,000 per full-time worker after the first 30 full-time workers, or $3,000 per person who takes a tax credit to buy in the exchange. And to take a tax credit to buy in the exchange, you can't be offered affordable coverage. So it might be clever for employers to sit there and offer premiums to you that are exactly 9.5% of your income. They qualify for their affordability protection, but for you it might still be very expensive, and you're now locked out of any subsidies in the exchange to buy coverage, and they avoid the penalty. So there's a lot of room in the ACA for employers to kind of game the system by offering you a reduced benefit package for exactly the level of affordability that is required by the law at 9.5% of their income, and to only offer coverage to their full-time workers, but drop all the other employees that they don't want to cover to 29 hours a week or 28 hours a week. So by setting it lower than we typically see for full-time workers, the ACA kind of inadvertently made it easier for firms to drop their workforce to 29-hour-a-week employees, and that's one big concern. The issue then becomes certain industries can do this and certain industries can't do this, right? So if you're working at a consulting firm, an engineering firm, an IT firm, odds are they're going to have to offer you benefits to keep you as an employee and keep you happy. But if you're in the restaurant industry, retail industry, manufacturing, it's very unlikely that the manufacturer or the company will feel like, if this person leaves because my benefit structure is very poor, they're still going to feel like they can replace them with someone else. So I think this will inadvertently kind of hit the lower wage, lower skilled industries more than higher wage, white collar industries, because the expectations around benefits are different and the way work hours work are very different. So I did want to get into the individual market reforms and then kind of wrap up and take questions. So in essence, what the individual market does is it allows what's called guaranteed issue coverage. So now inside and outside of the exchange, everybody who wants to buy coverage, regardless of your income, regardless of your disease status, regardless of your age, things except as long as you're under 65, you can buy individual market insurance coverage. Now, the undocumented are technically not allowed to buy in covered California, even with their own money, but they do get protection in that they can go to Blue Shield directly, buy coverage if they want to, using their own money, and they are now guaranteed coverage because of the fact that even if they have a pre-existing condition or something like that, they used to rule them out and exclude them, they're still able to buy coverage. Now, the premiums are now going to be rated based on only 3 factors in California. The ACA allows for 4 factors, including smoking, but California decided to ban the practice of using smoking status. So we'll only be seeing premium variation by age, the region where you live, and the size of your policy. And then the type of policy you buy, right? So if you buy an HMO or PPO or a different company, you could see variation in the premium. But within the same plan, you can only see 3-to-1 variation by age within that plan. So a 64-year-old might be charged $3 for every $1 a 21-year-old is charged. And right now in the individual market, on all these plans that are getting canceled, it was usually a 6-to-1 rating factor. So 64-year-olds getting charged $6 for every $1 a 21-year-old was charged. And then on top of that, the 64-year-old was getting charged twice as much for their diabetes, the risk that their thyroid condition or what have you. So you saw a really wide premium variation of usually 20-to-1 or 15-to-1 in the individual market currently, and now we're moving to this world where it's only 3-to-1. It'll vary by region as well. So LA has 6 different plans in most of the tiers that are offering coverage, and you'll see those plans being slightly different. But within the plan, if you're a 64-year-old, you could only be charged $3 more than the 21-year-old in that same plan in the same region. But if you're traveling between regions, you might see that San Francisco has platinum plans that are very expensive, and they're more expensive than the LA plans because LA's underlying healthcare costs are lower than the Bay Area's. In addition, in the individual market, some of the protections are the fact that there's a removal of annual lifetime limits and annual benefit limits. So no longer can an insurance company basically cancel your coverage after you spent $1 million of claims because of a cancer diagnosis or anything like that. And of course that causes premiums to go up a little bit. There's also this cap on out-of-pocket spending I mentioned before. So by law now in the individual market, if you spend $6,350 as an individual out-of-pocket, in network you're covered. After that you don't have to pay a dime more. For families it's $12,700. If you're signing up for a platinum plan in covered California, it's actually set at $4,000 and $8,000 because the plan is more generous. But that's a very good guideline to keep in mind. If I buy insurance and I'm an individual, the most I can spend after my premium is another $6,350 out of pocket. And I think that's a fairly comforting thing for most people because it used to be that there wouldn't be an out-of-pocket max in some plans or it'd be extremely high in the $20,000 range. Another thing to keep in mind that exists both in the current covered California market and the individual market outside of covered California is that we've now moved to what's called an open enrollment period for individual coverage, which never existed before. And it exists right now from October 1st until March 31st, 2014, where you can sign up at any time during that period and be covered in the coming weeks. So if you sign up by the 23rd of December, your coverage would start January 1st, as long as you pay by January 6th. If you sign up January 14th, your coverage would start February 1st. If you signed up January 16th, you missed the 15th as the deadline, then your coverage wouldn't start until March 1st. So you could be between 2 and 6 weeks off depending on when you sign up for coverage. The important thing to keep in mind though is that there is what's called an individual mandate penalty if you don't buy creditable coverage that covers your needs by 2014. you would pay this fine on your taxes. However, the federal government has clarified that if you sign up for coverage by March 31st, even though that coverage will start May 1st, you will not have to pay the individual mandate penalty. So even though you're only insured for 7 months out of the year, you would this year get a holiday from that individual mandate penalty. Next year, in 2015, you're allowed to be uninsured for less than 3 months only. And if you are uninsured for more than 3 months, you have to pay the full penalty for not carrying coverage. So this penalty is somewhat based on income and family size. And so it's being phased in over time. So this is for people who don't meet certain exclusion criteria, and the exclusion criteria include things like not making enough money to meet the tax filing threshold of $97.50 a year. So if you don't earn $9,000 a year, you don't have to file, you don't have to pay an individual mandate penalty. If you're in a recognized Indian tribe, you don't qualify for the individual mandate penalty. If you're in a Christian sharing ministry, you don't have to pay the individual mandate penalty. If you fall into like an Amish or Christian Scientist population that doesn't necessarily believe in the type of insurance we have currently and gets a waiver from the federal government, you don't qualify for the penalty. And again, if you're uninsured for less than 3 months, there's no penalty. And if you're undocumented, there's no penalty. And also, if you can prove that you have a financial hardship, there's no penalty. So there are lots of ways to get out of the penalty. However, if you are not meeting any of those criteria and you do have to pay the penalty, it will occur in 2015 based on what insurance you had in 2014. And you basically have to prove to the federal government that with the certificate that your insurance company will give you that I had creditable insurance for X number of months in the year, and therefore I don't have to pay the penalty. If you do have to pay the penalty in 2015 based on your 2014 experience, you'll be charged $95 per person in your household, up to $285 max, or 1% of your income. But income in this case is your total income minus the tax filing threshold. So if you earn $100,000, subtract $10,000 from that, you have the minimum tax filing threshold, and calculate 1% of $90,000. So it's not your whole household income, it's kind of your taxable income in a way. Then in 2014 or 15, it goes up a little bit to $325 a person. And then finally in 2016, it phases up to $695 a person, or 2.5% of income. You have to pay the higher amount. So people in very high income households, they would have to pay 2.5% of the amount that's above the tax filing threshold that they earn. But you have to remember also that people who earn over 400% of the federal poverty level, roughly $94,000 for a family of four, often have employer-based insurance coverage in our country. So as the income thresholds get higher and higher, most people have employer-based coverage. It's really the low-wage workers that the ACA really tries to target. So in terms of shopping in covered California, I think it's important to keep in mind what rating region you live within and making sure you buy a plan that will cover you in that region. So a good example here in LA County is the fact that we have LA Care, Health Net, and Molina that are local plans delivered in LA County, and you can buy if you reside in LA County. Next to them, we see Blue Shield, Blue Cross, Kaiser, and we see a Health Net PPO plan. So Health Net is not in every single network throughout the state. LA Care is not in every single network, but Kaiser is generally in most networks in most rating regions throughout the state. Anthem is and the Anthem EPO is in every rating region. So if you travel a lot and you use lots of services outside of your home city, you might want to buy a plan that has kind of a broad reach. You may not want to have that local network, because the local network is only required to provide you with emergency services out of network. They don't have to provide you with all services out of network. So I think it's important to keep that in mind as you're choosing a plan. So in San Francisco, Chinese Community Health Plan and Contra Costa Health Plan are offering coverage, but they're really targeted at the local population in those areas. And if you travel a lot, you may be out of network and therefore need to change. If people move, they're allowed to start, if their plan doesn't come with them because they're moving from one local area to another local area that doesn't have their plan in it, that starts what's called a new special enrollment period for 60 days after that move. And other things that qualify for the special enrollment period are having a baby, a death in the family, a big change in income that changes your subsidy reconciliation, the fact that you move from Medicaid due to your income change into covered California. So there are quite a few ways to start the clock again for open enrollment and give you another 60 days to sign up for a plan. In covered California, you have to be a lawful permanent resident or a citizen. You're not allowed to be undocumented. However, you could be here with a green card for any number of years and still potentially get a subsidy to buy coverage. And of course, as I mentioned, subsidies aren't available if your employer is already offering you affordable health coverage that's less than 9.5% of your wages. When you go into covered California, I'll just run through the metal tiers really quickly because I think they're important to think about as you're talking to your friends and family about what people need to buy. I get these questions on a daily basis, but there are basically 5 different tiers that you can buy into, but one of the tiers is a catastrophic plan that's available for people under the age of 30 or who have a financial hardship, and you'd need to get a certificate from Covered California showing that you had that financial hardship. So if you are shopping online through Covered California and you put in age 29, you'll see a minimum plan as an option. If you put in age 31, you will not see a minimum plan as an option. So the minimum plan is, the deductible is the same as your out-of-pocket max. It's $6,350 for a single individual. But some of the good things about signing up for that, especially for a young person, is that you get 3 free visits to primary care or mental health services, and you get a free wellness visit without hitting your deductible. So even though you have this huge deductible, if you feel like I'm only going to go to the doctor 4 times this year, and 1 is going to be for my physical, and 3 is just, you know, if I have the flu, you're getting all that service for free. If you sign up for a bronze plan, again, it's a $5,000 deductible. It still has a $6,350 out-of-pocket max for an individual, but after you hit the $5,000 deductible, your cost sharing kicks in. You start paying co-payments and co-insurance until you hit $6,350, and then the coverage starts at 100%. But you are allowed, prior to meeting your deductible, to get 3 visits for $60 a piece, and you get a free wellness visit because it's preventive services covered by the ACA for free. One thing to keep in mind, so the bronze and minimum plans look very similar to each other from a pricing perspective. They're within a couple dollars of each other. One of the important things though is if you do not get, if you earn under 400% of federal poverty level, so $46,000 for an individual, and you qualify for subsidies, you cannot use them to buy the minimum plan. You can use them to buy the bronze plan. So if you are lower income, it's probably better to buy the bronze plan than the minimum plan in many cases. If you're higher income, the minimum plan may make sense because you don't get any subsidies anyway. Now, the bronze plan is a $5,000 deductible. The silver plan is kind of the reference plan. That's kind of the backbone of the entire ACA with a $2,000 individual deductible, $4,000 family deductible. The copays are fairly high for a typical plan, but they're about $45 for a primary care visit, $65 for a specialty visit, $250 for ER visit. So it kind of looks like a high deductible plan, but again, it has the 10 essential health benefits, doesn't have many limitations, and you're still protected by that $6,350 out-of-pocket max. Now, another important aspect about the silver plan is that because that acts as the reference plan, that is what dictates what subsidy you get to buy coverage in covered California. So the second lowest silver plan in a region is going to be what your subsidy is linked to. And that's always going to provide you with kind of this baseline budget to decide what I can buy. So if you look at the second lowest silver plan in your region and it's $150, if you wanted to buy the third lowest silver plan in your region, it's $170, you would contribute that $150 to buy it, and then you'd still have to pay 20 bucks out of pocket. If you wanted to sign up for a platinum plan that's $300, you'd have to pay the difference, 300 minus 150. But at the same time, if you decide to sign up for a bronze plan, and that bronze plan actually cost $100, you would get a free bronze plan because you couldn't get any credit back, but you would use that whole $150 and just apply it to the bronze plan. So there is some concern that if people, younger people are likely to sign up for free bronze plans over silver plans because they view it as, I'd rather get a free plan with a huge deductible than a somewhat discounted plan with an easier deductible to manage. So keep that in mind. The gold plans and platinum plans have no deductible. The main difference I would say is the gold plan is still a $6,350 out-of-pocket max for single people, $12,700 for families, whereas the platinum plan will be $4,000 out-of-pocket max and $8,000 for families. So you're more protected on the back end with a platinum plan. and your co-insurance and things like that are 10% for the platinum versus 20% typically for the gold plan, even though there's no deductible. So your cost sharing is a little bit higher, but again, throughout the individual market, wherever you buy, you'll still be protected by that out-of-pocket maximum set at $6,350. The problem will become if you go out of network, either in an HMO or a PPO, the out-of-pocket maximum doesn't work the same way. It's really only designed for in-network services. And what was mentioned by Dr. Rogers before is a very important dynamic to keep in mind where if you go, he mentioned this whole thing about physicians balance billing, and he acted like that's the standard. It's actually not the standard. If you're in network, health insurers are not allowed to health insurers are contractually obligated to pay a negotiated rate to a physician, and the physician is not allowed to charge you anything else over that negotiated rate. It's illegal for them to do so. But if you're out of network, they don't have a contract with your insurance company. So they're allowed to charge you a specific amount of money. The insurance company is allowed to pay what they want to pay, and then you're still responsible for the remaining amount. And if they're doing that practice of balance billing, it does not count toward your out-of-pocket maximum. So you have to be really careful about being out of network. So I think it's important to think about the network that's available to you in the exchange. Look very carefully at the plans available. The information is out there. You can go on the Covered California website and select a doctor, save that doctor, and it'll show you with a check mark or a minus box if that doctor is in the different plans you're shopping around for. And also if you go to the websites for Blue Shield, Kaiser, HealthNet, you'll be able to look at the plan and select Covered California Silver EPO, and you'll be able to see what physicians and hospitals are in that network. But for somebody who's thinking, well, I really want to go to Cedars-Sinai, but I want to sign up for the Blue Shield PPO plan, Cedars-Sinai is definitely not in the Blue Shield PPO network. It is in the HealthNet PPO network. So even though you have this preferred provider option of going outside of network and paying more out of pocket, you're still not protected from that out-of-pocket maximum that you would be if you stayed in network. So be very careful about that, especially if you're going to use a hospitalization outside of network and it's not an emergency, because hospitalizations, a hospital could decide to charge you $90,000 for that, and it won't, because it's balance billed, it won't count toward your out-of-pocket max, and you could be sitting there with a $40,000 bill or something like that. So not to scare you, but just be cautious about this perception that a PPO gives you unequivocal choice and protects you. It doesn't actually, because of the fact that doctors who aren't under contract with insurer are allowed to charge you what they want. So in terms of helping people buy coverage, I think the price protection is really important. We know what pricing will be in the individual market, and that's one of the big issues with these plan cancellations. Nobody knew what individual market prices should be, right? We were using disease status and risks to market healthcare to people. Insurance companies were making lots of money off that practice, and now they've leveled the playing field, and all of a sudden they have to just offer a standard price, and there's a lot less kind of ways to game the system. So I think we will see that price transparency be really helpful over the next few years as things level out, and you see insurers not able to game the system to try to get healthy people to sign up for their plan at the expense of other plans. The subsidies that are available to people in the individual market are advanced premium subsidies. They're advanced premium tax credits. So it's important to make sure you're updating your income over time if you qualify, because if your income goes up too much, you could be subject to paying some of that back, if not the whole amount back if you make too much money. The other thing that's happening also is what are called cost sharing reductions that you should be aware of. And that means that if you are under 2.5 times the poverty level, so this is like, $62,000 for a family of 4 or something like that, you would actually qualify for enhanced silver plans in that market. So rather than getting a silver 70 plan with a $2,000 deductible, you would be offered a silver 73 plan that has a $1,500 deductible. If you go down to 2 times poverty and you only make $40,000 a year for a family of 4, you would probably be offered an enhanced plan that had no deductible and more cost-sharing protections. So if you're fairly low income, just above the Medi-Cal threshold, but in the Covered California tax credit threshold, you'll have a very inexpensive premium, because the premium will be capped at 2% of your income or 3% of your income. And on top of that, your out-of-pocket max will only be $2,250 for an individual. You'll have no deductible, very low cost sharing, And so there are these very inexpensive, comprehensive, enhanced plans that are designed for people at lower income levels, even in the exchange. But you have to sign up for a silver plan to get it. They aren't linked to the bronze plan, they aren't linked to the gold or platinum plan. So if you have low income people coming through and they need help kind of choosing a plan, say, the silver plan that pops up first is probably the best deal for you because it gives you this enhanced package that the other plans don't. So I think, those individual situations will be really important to think through. There are people that their kids will qualify for Medi-Cal because of the fact that they earn under 2.5 times poverty, but the parents qualify for Covered California. They could choose to forego the Medi-Cal coverage and put their kids in with them in Covered California, but they will not get tax subsidies to help pay for it. And so families are making these decisions about the network, about the mix of services they need, and where their kids should go and what kind of continuity they want. So, the good thing is that people have lots of options now. Before, the option was, I hope this insurance company gives me coverage. I went online, I entered my information, they told me what my premium should be, it's going to be a $10,000 deductible, and then they sent me a questionnaire that I have to fill out. And if I show up on any of those things as a risk, they're going to deny me. And now you don't have that situation anymore. People are guaranteed to be able to buy coverage as long as they sign up in an open enrollment for a reasonable price, and they possibly could get tax credits and subsidies to help them afford it. And that's something we've never seen before in the US. And if people's job situation changes, if their income changes, they're always covered. So, you've seen some people have said the ACA will cause more divorce because people won't be stuck in marriages because of health benefits. But it could also cause more small business creation. It could cause people to be more flexible in the way they work and the hours they work because of the fact that even if they don't work as much, and even if they don't qualify for benefits through their workplace, they always have this new option available through Covered California. I think that's a really important thing we seem to forget here, where it provides this level of flexibility to keeping benefits and not having to worry about losing them because your job changes or losing them because you get a divorce or something like that. So I think with that, I'll take any questions you guys have, and thanks for listening.